Hello. Hello, everyone, and thank you for joining today for the POCUS Certification Academy and today's POCUS Bites webinar. My name is Daria, and I'm the Global Learning Program Manager with POCUS Certification Academy, and I will be your host today. The webinar is now beginning, so all the lines have been muted. Please use the Q&A box for any questions in the chat, and also for any comments that you would like to have throughout the webinar. The presentation will include a PowerPoint presentation and a time for a Q&A with the speaker. And today's topic is ultrasound gold standard for evaluating placenta and twin pregnancy. And our speaker is Rawan Alsukairi. This is our third webinar with Rawan. Two of the previous webinars can be found on our website, and this is our final webinar with Rawan. Thank you again, Rawan, for joining us today, and we're so excited to hear your third and final webinar with us. Welcome.
Thank you, Daria, and thank you everybody for coming. And I am glad to meet you again, even though it's the last time, and hopefully it's not the least. Today we are going to be talking about the third trimester. And for those of you who missed the first and second, the recording is in POCUS website. So our objective for today is going to be a quick review for placenta implantation and placenta previa, as well as answering a question for somebody who have addressed how to diagnose bilobed placenta. We're going to be touching on measuring AFI, as you will have to do that in third trimester, twin pregnancy, setting up twin pregnancy worksheet, and fetal biophysical profile and situs. This is highly important. So this could be it require your focus. So for those of you who might need to review this again, the recording of today's webinar as well is going to be on the website. So we're going to start with a quick review from last webinar with a quick multiple choice question. Which of the following is the correct answer about the placenta? What do you know about placenta? And here are the choices.
We are at about 40% of people answered, so feel free to click on the poll with questions and answers. So you're 50%, so I'll give another 10 seconds for one. All right, here's your results.
So everybody answered correctly, almost. 92% of you, maybe those A and B were in a hurry, so slow down. It's actually all of the above. Placenta is the organ that develops in the uterus during pregnancy. It provides nutrition and oxygen to the fetus, and it removes waste product from the blood as well. Second question, what is abnormal attachment of placental villi? Which kind of abnormality is it when the placental villi to the uterine myometrium causing defect in decidual basalis? Is it acrita, anacrita, or pracrita? If you forgot, it's okay. We're going to review this in the followed slide right after this question.
We are at about 50%, so I'll give another 10 seconds. hear your results.
So we had random, interesting sort of answers, and only 39 answered correctly. It's placental increta. How many answered? So what will happen in here? We have the normal placenta implantation, where you see the placenta is attached to the uterine wall, the inner wall of the uterus, without going beyond the myometrium layer at all. Then with Akrita, you will see the placental tissues going beyond the level of the myometrium. It's interrogating the myometrium, and which was the correct answer. With Anacrita, it's invading the myometrium completely. Whereas with Paracrita, it invades the myometrium completely, and it goes way beyond, all the way to where the bladder is located, or the bowel, if it's not the urinary bladder area. So the last question, which of the following are types of minor placenta previa? Remember, we had minor and major previa. So which of those is the minor previa? So those questions, the previous question, you would need it more for the board exam when you are going for your RDMS, more than when you are doing the diagnosis. So it is more of knowledge base. But for this one, minor or major previa, you would want to know how to distinguish which is which, because you are really diagnosing the previa yourself while doing the exam. So the majority of you answered low lay placenta and marginal previa, which is good. I am really happy. So here is again the minor and the major previa. The minor, we have the low and the marginal, because low, it's just low. It did not even cover the internal OS. Marginal previa, it did not cover the internal OS completely, but it's starting to be really close to there. Major previa again covered the internal OS completely. Either only third of the placenta is down, whereas the 3/4 of it is still up further, or 50% of it in the right side and 50% of the placenta on the left side in case of complete previa. So I am glad you figured this out really well. And again, as a reminder, if I detected or I was questioning previa while doing the exam abdominally from her belly, at that minute, I will have to do the exam endovaginally, do the endovaginal ultrasound scan for better look, closer look, in order to be able to measure the distance from the internal OS into the tip of the placenta correctly. So now here is to answer somebody's question in how to diagnose bilobed placenta, or what we call it succintoriate lobe of a placenta. At that time, you will see the placenta, you will see a posterior portion of a placenta and anterior portion of a placenta. And what will be the key is having the vessels connecting the two of them within the fundal part of the uterus. So this would be your key to distinguish this is a bilobed placenta in comparison to this is just anterior fundal or posterior fundal. That is not like a folded or bilobed one. I hope this answers your question clearly. So anytime we have bilobed placenta, look at the sign, using color Doppler gonna help you much better to see the connection in between the two and how each one is in different side of the cavity. So you will know it's bilobed rather than what you called it in your question, right lateral or left lateral. So moving into the amniotic fluid, its function is to maintain intrauterine temperature, allow the fetus free movement within the amniotic cavity. It protects the developing fetus from injury and prevent adherence of the amnion to the fetus itself. It allows symmetric growth. So here is measuring the amniotic fluid. We would do, rather than dual screen, 4 screen, to measure, you have to be measuring perpendicular. You will, in every section from the belly of the pregnant, I would measure the widest, largest pocket, and the cursor has to be perpendicular, 90 degrees. If it's not perpendicular, it will give you non-accurate measurement. And you have to be doing the measurement at the level where I don't have umbilical cord. Anytime there is umbilical cord, it's wrong measurement. So within all of those 4 images, you do not see umbilical cord within the amniotic fluid. So anytime the machine will add up the volume itself by measuring all those 4 quadrants. Anytime the AFI is below 5, it's a sign of oligohydramnios. If it's above 24, it's a sign of poly. And we don't want to have any one of those because those are associated with chromosomal abnormality and syndromes. So here is another representation, a picture of measuring the AFI in the 4 quadrant. So prognosis of oligo, why I don't want to have oligohydramnios increase, risk of fetal death and neonatal morbidity, cause umbilical cord compression. During first half of a pregnancy, oligo will cause high miscarriage risk, impaired lung development, birth defect as a result of compression in the baby itself, without that enough volume of the fluid. Within the second half of a pregnancy, what will happen, she's gonna have a preterm birth, baby experience reduced growth, or what we call it, intrauterine growth restriction, high chances of fetal distress during labor. This is often necessary. It will be this pregnant gonna have to go through C-section. So fetal well-being, or what we call it biophysical profile, is indirectly testing for fetal hypoxia, or the level of oxygen within the baby, which will allow you to determine whether the fetus is in distress or not really. Non-stress test will be finding fetal tone, the fetal breath, body movement are the markers for acute fetal hypoxia, the drop of the oxygen concentration. So biophysical profile protocol would be fetus would be, we will have to be observing that baby who come to the clinic for biophysical profile exam within 30-minute limit. You should not go beyond the 30 minutes, so you should time yourself when doing this exam. And during this, we're gonna be looking at 5 parameters to evaluate, which are fetal tone, the movement of the baby, the breathing movement, and the amniotic fluid index, AFI. Non-stress test or placenta grade as well. So you will have to be looking at the grade of the placenta, as remember placenta progress in pregnancy and will be in different grade from 0 to the term will be in grade 3. So the scoring system would be, we give any one of those parameters 0 if it doesn't exhibit, like if supposed the baby did not move at all, we're gonna give it 0. We give it 1 if it's partially exhibiting, and we give it 2 if it's fully, if it's existing fully and we are satisfied. we give it 2. So within all of those, multiplied by 2, I want to have a score of 8 for normal baby. So fetal tone is one complete episode of a flexion or extension of the baby and back to flexion again while you are doing this exam during those 30 minutes. Fetal movement, there must be 3 separate fetal movements within 30 minutes. So you don't want to go only, you don't want to have the baby moving once and call it a full movement. It has to be the baby moving 3 times within those 30-minute limit. Fetal breathing is the movement of the diaphragm. So I will have the baby in sagittal view. I will look at the diaphragm where it's separating the abdominal cavity from the chest cavity. When I see the diaphragm is moving, so I know that this is the breathing of the baby. So I want to see the movement at least greater than 30 seconds. So if I see the diaphragm is moving, you're going to be counting 1, 2, 3, 4, 5 until 30 seconds. So then you're going to give it full score of 2. And then the AFI again, I want to have at least 1 pocket is measuring greater than 2 centimeters. If I don't get 1 full pocket greater than 2 centimeters, I'm going to give it 0. Then with non-stress test, it exhibits 2 fetal heart acceleration within 20 minutes or placenta grade above 2. Total point of 8/8 is a sign of normal biophysical profile. If it's below, it's not normal. Any biophysical profile score below 6 or 6 completely is abnormal. Twin pregnancy and fetal presentation. So this is a really need your focus in here because you're going to be lost if you don't pay attention from the beginning. Twin pregnancy. So we have type of a twinning, either dizygotic or monozygotic. So what do we know about it? If it's monozygotic, so we have with monozygotic, it's single ovum, 1 egg fertilized by 1 sperm. That 1 egg is that got fertilized by 1 sperm from million of sperms. It's divided into 2 to give us the twins. Whereas with dizygotic, we had 2 separate ovum or 2 separate eggs got fertilized by 2 separate sperms in order to give us the 2 twins who are dizygotic. That's an anatomy and general concept. Moving forward. So in ultrasound, it's extremely difficult now at this point to know whether that fertilization was dizygotic type of fertilization for the whole scenario or monozygotic type of fertilization. We don't know yet. So now what will happen, you probably, if you are beginner, you have heard of di-mono, mono-mono, and you don't know what those are. This is now what I want to explain to you briefly. So we had the scenario where we had 2 twins. They were either monozygotic or dizygotic. So dizygotic twins, here we have a dizygotic twin. This is 1 egg fertilized by 1 sperm, and it gave me the twins. It gave me dichorionic, diamniotic. So 2 fertilization events occur at the same time, result in fraternal non-identical twin. We call them di. So we have 2 different ovum with 2 different sperms came at the same time, and they gave us di baby, diamniotic, dichorionic. Monozygotic twin, which are identical, those the monozygotic, which was only 1 ovum. When we compare the above line to this below, you can see at the really top of this image, we had 2 ovum, 2 sperms came at the same time, and they gave us di twin. Whereas in here, we had only 1 egg, 1 ovum, and 1 sperm. This can result either in di which we already had with 2 separate sperms and 2 separate eggs. So di twins can come as a result of 2 different sperms fertilizing 2 different eggs, and can be also a result of 1 egg fertilized by 1 sperm. Both of them, those 2, are sharing one thing, that the 2 of them can produce di twin, diamniotic, dichorionic, we call it. But those other scenarios, mono-di, mono-mono, those only can come through the monozygotic type of fertilization, which is 1 sperm fertilized 1 ovum, and it gave us mono-di or mono-mono. We will talk deeply about what is this, why di or di-mono. Now you will know in this slide. So here, the amnion versus the chorion. When we speak, we are speaking of amniocity and chorionicity. The baby here is located in 2 different sacs. The one that looks so thin and the really thick one that resemble the entire uterus or attached to the uterine wall. The really outermost one, the outermost cavity, is what we call it the chorion, whereas the innermost cavity, that including the yolk sac with a really thin wall, I call it the amnion. So this fluid, now the one really closer to the baby, the inner bag, think of it now as the amnion, whereas the outer one with thicker wall is the chorion. So we are speaking of chorionicity or amniocity based on those wall, the inner or the outer. So the amnion is the membrane that surrounds the embryo. When I go back to this fetus, see the membrane surrounding the baby? This membrane is what we call it the amnion, okay? Whereas, so it's the amnion forms the amniotic cavity, as I just explained. It does not communicate with the chorionic cavity at all. Those are separate. As more fluid is produced, the amniotic membrane expands toward the chorion. It pushes itself further away. By 14 to 16 weeks of menstrual age, the amnion and chorion will be joining themselves together. So in case where we have monoamniotic, monochorionic, the further that amnion with the pregnancy, as the pregnancy is developing with time, the more that amnion, let us go back to the picture. As further we go in pregnancy, as further this amnion, amniotic membrane will be pushing itself further until the 2 become next to each other's. In case of, I will call it by the end, mono-mono, monochorionic, monoamniotic. Okay, and then, so mono mean 1, di means 2. The inner sac or the thin membrane, the one immediately surrounding the baby, we call it the amnion or amniotic cavity, whereas the outer one is the chorionic one, the chorionic cavity. So here, you want to have to pay attention to this to put all of those together. We have 4 different scenarios. We have the inner and outer wall. Mono is that both babies, baby 1 and baby 2, are sharing together the inner and the outer bag. It's connecting them. It's connecting the 2 of them. See this line, if you look here, you will see one line and that's the other line. The inner one is the one for the amnion. The outer one is the one for the chorion. They are together in one bag, like they are in one balloon. As they are together, they are monoamniotic, monochorionic, because they are sharing. Here we have monochorionic, diamniotic. Why? Diamniotic means di again is 2. Amniotic means the one is appeared to be 2, is the inner sac of each baby. So each baby is covered by one inner bag, whereas the outer one that we called it chorion is covering the two of them. The outer bag is covering the two of them. So that's the monochorionic, whereas the inner one, each one is having its own inner bag. So we call it amniotic. I know this could be challenging, so you can review this again when you see the video posted. And in here, they can have two different situations. All the bags are doubled. The inner one, which is the amnion, each one is having its own one. The outer one is the chorion, each one is having its own outer sac too. But in here, beside that, they are sharing one placenta. See, if you look at the wall, it's double wall and having shared placenta. This one too, they are di as well. Each one of them is having double wall because the inner wall is the wall of the amniotic sac. The outer one is the wall of the chorionic sac. Each one of them like that, but each one of them is having his own or her own placenta. They are not sharing. So di twins does not necessarily have to be sharing placenta. We do not say always in medical, they are in separate placenta in here, they are in shared placenta in here, even though they are di. Both of them are di. So again, really quick review, the mono, shared bag, the inner and outer together. Monochorionic diamniotic, only the inner wall is separate. Each one is having his own amniotic cavity. That's why we call it diamniotic. The outer bag is connecting the two. They are having the exact one outer bag. So in ultrasound, the monochorionic diamniotic, they will have the T sign. Look, this look like letter T. Whereas the di, this is really thick in the middle, is the lambda sign. We call this one the lambda. I will show you in the images in the upcoming slide. So this is the T sign because it's really thin. T sign, really thin, so it will be diamniotic. Monochorionic, diamniotic, because they are sharing the outer bag that we called it the chorion. And the inner one, each one is in a separate bulb or separate bag and really thin in the middle between the two. So this is diamniotic. So T sign, diamniotic, it's really thin membrane in between the two baby. Memorize this, you will be good to go. Whereas this, the really thick, look like lambda, the lambda sign between the two baby is immediately gonna let you know this is actually di. This case, chorionic diamniotic, because it's lambda. So dichorionic versus diamniotic, when is it best to evaluate their chorionicity and amniocity? The best time to do this would be as soon as possible, the really first trimester, because by that time, first trimester, when you don't even see the baby in here, it's easier because everything is small. That time is the baby by the size of rice, whereas the further the baby grow, the more challenging it will be for you to tell which is which. So now here I have side by side both scenarios, the diamniotic or the dichorionic. The diamniotic, because this is thin membrane, T sign in between the two of them, whereas the outer one is connecting the two. So this is diamniotic monochorionic. In a lot of literatures or a lot of people, doctors, they drop the monochorionic part. They don't say it when they want to talk about this type of a twinning is, if they want to say this type of a twinning is diamniotic, they will not say to you, it's diamniotic monochorionic. They will just say it's diamniotic and that's it. they cut the monochorionic part, they erase it, because they will know you automatically gonna understand it's monochorionic. No need to mention that. It's more important to know it's diamniotic. But if you hear you say, oh, this is dichorionic because of the lambda sign, you will know it is di immediately. Any dichorionic means it is di. It's dichorionic, diamniotic. But for the case of diamniotic, I can just say diamniotic and I am good to go. I hope you are all following and we are good in here. I will look at the questions by the end. So here again, monochorionic diamniotic twins. As I said before, we can drop the monochorionic parts and only say it's diamniotic, we will know. Because here, a thin membrane in between the two baby, the thin membrane is the inner membrane, the amniotic membrane. That's why we have two of those. So this one is diamniotic. Monochorionic because one outer is connecting the two, and here again, thin membrane look like T. Each one is in separate inner sac, so diamniotic, monochorionic. Another way to tell, to read the number of amnion is by using the yolk sac, which look like the ring. If I see them too, I immediately gonna know or use it as a hint that, oh, this is actually diamniotic. Here is the dichorionic because of the lambda sign, thick membrane in between the two, lambda sign, thick membrane in between the two. So I know in here, this is di. Monoamniotic, monochorionic, in case of it's shared for everybody, you're gonna see both babies together. You cannot see the other sac. All you see is just the outer sac and the two baby. So now life is easier. This is just mono. All of those are mono. Even in here, you can see a little amniotic membrane and loss of resolution. You cannot see the entire circle, but you see them together. So you know here, this is mono. One yolk sac, it's mono. And both babies are together at one bulb. So monochorionic diamniotic, again, that's as a review, diamniotic, it's only the inner. Here is the inner membrane in between the two. And here, the resolution is bad in here, I apologize. And here too, thin inner membrane in between the two. So it's diamniotic, monochorionic, because the outer, the chorion is connecting the two. Diamniotic, dichorionic, which we said this is with lambda sign. Remember, because we can see the lambda again, so it's di. The lambda help you. It's really thick in between the two. So here also, I love this one too, this picture on the right side. Why? Because of the lambda, I know it's dichorionic. Because of two yolk sac, I know also it's diamniotic. So here, it's giving you all the hint in this particular image with a really good angle of the probe, showing me everything I need to be using as a hint. Or here too, thick membrane, lambda sign. Anytime immediately you see lambda sign, you know it's dichorionic, but also you see the thin amnion of each one. So definitely this is di with, you have the proof of everything. So twin-to-twin transfusion syndrome. Remember, we talked about the di, that they can be either each one of them is having separate placenta or they are sharing a placenta. Having the baby sharing a placenta is not good. This situation is gonna cause what we call it twin-to-twin transfusion syndrome because of anastomosis between the vessels coming out from the babies within the placenta are connected. So one baby is gonna be receiving more nutrition and blood, and the other one is gonna be the donor. The donor is gonna be measuring way smaller or restricted from growth, the recipient gonna be measuring way bigger, way beyond normal as well, and will be having polyhydramnios. The donor gonna have oligohydramnios. The donor is not gonna survive in most of the situation. And if the donor die too, and they do not do C-section and take out the recipient as soon as possible to manage the situation, even the recipient could die. So it's unique to monochronic diamniotic twin pregnancy. Diamniotic, remember, each one of them is having his own amnion, characterized by imbalanced blood exchange between twin circulation because of the interplacental anastomosis, as I explained, marked growth discordance in between the two, significant weight discordance, poly at the recipient and oligohydramnios at the donor. The incidence, twin-to-twin transfusion syndrome complicates 15% of monochorionic twin, is responsible for 17% of perinatal mortality. So when could we say that those babies are identical? If ultrasound show both baby in one gestational sac that they are monochorionic with no dividing membrane in the middle, so they are monoamniotic as well, they are mono-mono, they're gonna be identical. In short, mono-mono are 100% identical, they are monozygotic twins. If they carry the same genetic package, they are both either boys or girls. But in case of di-di, they may or may not be identical. Remember, the di-di can be coming from two different sperms at the same time, coming to fertilize two different eggs in one scenario, or in another scenario, we could have get di-di from one sperm fertilizing one egg, that egg divided into two. So in this case, they may or may not be identical. So we go by the genes and we cannot rely on ultrasound anymore at this case. The best way to determine if the twins are identical or fraternal is by examining each children's DNA, because remember, di-di, as I said, can come from monozygotic root. Identical twins have the same DNA, but they may not look exactly identical to one another because of environmental factors. So ultrasound worksheet of twin pregnancy. When you have a pregnant of a twin, you do not want to proceed immediately to the exam when the machine is set as there is only one baby. You have to change in the machine within the preset prior to proceeding with the exam to the number of baby we have, whether 2 or 3 or 4. So it will allow you to be showing how many fetus do we have. So when I do the exam, I'm gonna start with the baby is closer to the internal OS. We call it baby A or baby 1. You will start doing all the measurement, all the parameters for biometry, abdominal circumference, head circumference, BPD, and femur lengths, the umbilical cord Doppler, the heart rate of that baby first. So you are sure that the machine is recording every single measurement you are doing. Then when you are done, you will switch into the machine to baby B to start the gathering all the measurements for baby B. So you have to be remembering to do this and not to forget, so the two do not get mixed. And you will have to, even if your protocol, you have to label on the images you save, this is baby A, start putting the label baby A, do the measurement, and then erase, make it baby B once you move further into the second baby. It would be easier to take one baby at a time than jumping in between the two. So which one to start with? I already mentioned we're going to start with the one closer to the internal OS, whereas the one further up above, closer to the fundus, we call it baby B, as you can see here in the label. Baby A is the one down, baby B is the one up above, further away from internal OS. So AFI in case of a twin, so again, we're gonna be, for AFI, it's applied to a twin gestation. It doesn't make, it's not, does not take it into account for the membrane placement. The MPV measurement may cross the membrane and go from one twin to the other. So the measurement for amniotic fluid index identify 94% of a twin pair as having normal amniotic fluid volume when only 52 had normal volume. So it's really challenging to measure the amniotic fluid in case of a twins. So the membrane in the case in the center is a huge help. If the membrane is at the middle, the amniotic membrane which is really thin, is in the middle between the two, it will help you in doing the measurement. You go perpendicular, then you go horizontal. So fetal presentation and situs. This is, we are 6:41 minutes already, and this is also huge. So if you have to run, don't worry, this is recorded. And if you have nothing to do, bear with me because you need to understand this. And if you have a doll, you might need this now at this minute. So vertex, or what we call it, cephalic presentation, is when the baby's head down, regardless whether the spine is anterior or posterior. We don't care. All I care about now is that where is the head is pointing to. If the head is pointing down, we call it vertex or cephalic presentation. Transverse head to the right maternal side is the baby laying on the side and the head toward the mom's right side. So the baby can be laying this way. This one is not gonna be able to deliver naturally as easy as with cephalic when the head was down. Breech presentation is when the baby is sitting on the butt. Complete breech, head up. And this is also challenging to be delivered naturally. She will need a C-section. And breech footling is when the baby is in the butt, but one of the foot is going down. We call it at this point breech footling. Breech frank is the baby also in the butt, but both of the feet are going up closer to the face. It's difficult with this baby. She is chubby. So you can see it in the image. So, and in here, another example of baby presentation, as you can see in ultrasound. This one is breech because look at where we have the internal OS, baby's head is up above. So this cannot be cephalic, or we call it also vertex at all. Here we have the baby and a transverse head to the left maternal side, spine posterior, twin baby presentation as well, both the twins. Both of them, I don't have another baby. I have only one I bought. We remember we bought those during college days and for a clinic in order to put those together. So both babies are cephalic in this situation. And it could be one is vertex, or we call it cephalic. The other one is breech. The other one having butt down. Or it could be one of them vertex, whereas the other one transverse head to maternal left side. And both of them are breech in this situation too. When both twins are a breech, a planned C-section is recommended because your doctor is not able to turn the fetus. It will be difficult to do the vacuum for 2 babies rather than it's only one. It's more challenging now. Studies also show that there are fewer negative neonatal outcome for planned C-section than planned vaginal birth in breech babies. And now this is what you need to know while you are doing the exam. Speaking of situs. So now we know how to name them: vertex or breech, or transverse head to maternal right side, or transverse head to maternal left side. Putting those together during the evaluation, when we scan, we know the portal splenic confluence and the stomach with the spine is the level where I measure abdominal circumference. Portal splenic confluence is within right lobe of the liver, so that's the right side of the baby. Stomach is within the left side of the baby, and the apex of the heart has to be also pointing toward the left side of the baby as well in normal situs. So you have, now we know the normal situs. If it's the reverse, the portal splenic confluence is not within the right side, or the stomach is not within the left. The apex of the heart is not pointing to the side where we had the stomach, because the apex of the heart has to be pointing at the area or at the direction where we had the stomach. If it's not pointing to the left to where we had the stomach, it's not normal situs. And I have to know the baby presentation, label it while evaluating for situs. So now we are speaking of a breech presentation, baby sitting on her butt, head is up, she is on the butt, and the spine is posterior. So the baby is facing me during the exam. If I say spine is posterior, means the baby is facing you during the exam, because the most anterior part of the baby is the belly of the baby, not the spine. The spine is the most posterior one. So this is why it's called breech with the spine posterior. So here at the beginning, spine is posterior. This should be the right side because of portal splenic confluence. This is the left side because of the stomach. Here in ultrasound, you will obtain 2 images, and you would want to know, you would want to put this in your head, how is the baby sitting. So you know how the baby is sitting, so you know what to expect. I am expecting the spine to be posterior. So our posterior is the bottom of the circle, or the bottom of the screen. Is the posterior is where the spine has to be sitting. This is the spine. The 3 dot is a representation of the spine. And that should be right side. This should be left side. Right side is having portal splenic confluence. Left side is having stomach. Yup. Spine posterior on the right side, portal splenic confluence, and the left side, the stomach. Then when we move the transducer at the level where you see the 4-chamber heart with the apex of the heart and still spine posterior, you see the apex of the heart is pointing also toward the left, which is the side where we had the stomach. So this is normal. Because look at the baby too. Put all of those together. I look at the baby. This is her right side. Her right side is the one has to have portal splenic confluence. Yes, it does have it. Her left side is the one is supposed to have the stomach. Because, yeah, looking at it, so I know when I look at it, this is the right, that's the left. And the left, I see the stomach, apex of the heart pointing to the left too. Yep, so this is normal. Here is how the baby is sitting. So, because maybe now when I am holding this mirror image or something is making it the opposite for you. So when you look at this, you know, baby is a breech. The anterior part of the baby is the belly, or the umbilical, the umbilicus, whereas the spine is the most posterior one. So the spine has to be at the bottom because it's posterior. And that's the right, that's the left. The right having portal splenic, the left having stomach, and the apex of the heart pointing toward the left. We are good to go. Normal. Okay. So now here is the ultrasound image with the spine posterior, spine at the bottom of the screen, spine is posterior. Right side, this side of the baby is the right side. This is the left side of the baby. And you see portal splenic confluence, and you see the stomach. And then the apex of the heart is pointing to the left side. See, here is the apex. It's pointing to the left, like if it's going clockwise to the left. So I know this is normal. Here is another scenario. I hope everyone is doing well. Breech presentation, but the spine is anterior. Spine is anterior, mean during the exam, the baby is giving me her back. This baby is giving me her back. So when she is giving me her back, her spine is the first thing I see, whereas her belly is far away. So the spine is anterior. This is why I want the spine to be anterior at the top of the circle. It's anterior. While she is this way, she is like me. We are all facing the same direction. So our right and our left are the same for me and for the baby. So her right side is expected to be here. Her left side is expected to be at this side. So this is the right side having portal splenic confluence. Left side is having stomach for normal situs. Then again, spine anterior, right side having portal splenic confluence. Left side is having stomach. Apex of the heart is pointing toward the left as well. It's not pointing here to the right. It's pointing there, like if it's going clockwise to that direction, which is the left. So this is normal. If it was the opposite, if a stomach supposed to be in here, where is portal splenic confluence in there, I know there is something wrong. So here again, for you, you can imagine it, baby is a breech, but the back of the baby is the most anterior part toward you. So seeing the back means now the spine anterior. The right is right and the left is left in this situation. This is why we labeled in here left side of the baby, right side of the baby is supposed to be in here. So this is an ultrasound again, spine anterior, spine anterior, spine anterior. Stomach to the left, portal splenic confluence to the right. This is the portal splenic confluence. Then at the level where I see the four chambers pointing here to the left. Spine anterior, so this is normal. Another scenario is baby is a breech. The baby is not going to be sitting exactly the same with everybody. They can be sitting however they want. So that's why we're going to have different scenarios of situs. So we're going to, they don't let the baby fool you. You put those together, understand that it's going to get easy and simple. Breech, so butt is down, but the spine is toward maternal right side. Or it could be also breech and the spine toward maternal left side. But now we are doing it with breech and the spine to the maternal right side. Again here, spine to the maternal right side is expected to be here. So in this situation, if I look at her, I know the right side is the one more anterior, because remember in anatomy, when we cut in anatomy, the plane, the sagittal and the transverse, now I have to have anterior and have to have posterior also is applied to this situation too. Spine is to her maternal right side. To me, the most upper part of the baby is her right side. This is her right hand. This is why If the right side is the most anterior, here in the image, the most anterior part is at the top of the screen. This is why I will call this part is right. So I'm gonna be expecting portal splenic confluence to be here at the top of the image and the stomach to be at the bottom of the image, which is the thing below the posterior portion that is behind what I see. So it's the bottom. The bottom is going to be the left. You can memorize them too. You can memorize if it's breech spine to the right maternal side, it will be her right side at the top, her left at the bottom. Whether you are a memorizing body who just memorize, or whether you are one who cannot memorize at all and has to understand and put things into what they mean to you, you're going to have the baby in your hand. So spine toward right maternal side. Where is her right? This is her right. Her right is the most superior anterior. So here at the top of the image, I'm going to have portal splenic confluence. Her left is the one at the bottom. So the left is in here, is the stomach. So here they are corresponding. Spine, right side at the top, having portal splenic confluence, left side at the bottom, having the stomach. The apex of the heart at the level of the four chambers view is pointing also down to where we said the down or the bottom is the left side. So it's correct situs. And here again, showing you spine to the right maternal side, baby in breech. So this side, this arm, and this shoulder or this ear are the right side of the baby, which is here the more superior. More superior means anterior, right side. So it's in here at the top. The posterior or the left, I don't see it while he is sitting here. So it's the one at the bottom. Hope this makes sense. And here, ultrasound image of the situation, spine on the right maternal side, spine on the right maternal side. Then at the top is the right side, portal splenic confluence. At the bottom is the stomach. And apex of the heart is pointing to the baby's left side down. Breech and spine to the left maternal side. Now this baby decided to be pointing the spine to the maternal left side, to the side where the mommy has her spleen and left kidney. So at this time, the baby's right side is actually the one at the bottom. The baby's left is the one at the top. So now it's the opposite. The stomach has to be at the upper part, the portal splenic at the bottom, as we are now expecting the right side to be at the bottom of the screen. And here is the spine pointing toward mommy's left side. Here is again another example to show you. Spine pointing to the maternal left side in breech presentation. And it's here is the spine, the three dots in the left side of the mom. The left having stomach, the left having apex of the heart pointing toward the left too in four chambers view. Portal splenic confluence within the right side, which is the bottom of the screen. So we are good, normal situs. Again, here is the spine, the hyperechoic three dots in here and in here to the mommy's left side, and the left of the baby at the top of the screen, the left, the apex of the heart. See, here is the apex pointing to the top, which is the left side, so correct. And the portal splenic confluence at the bottom, the right side. So that's correct as well. If those were reversed, the stomach and the portal splenic confluence and the apex of the heart is not pointing to the upper part, it's pointing to the bottom. I know I will call it situs inversus. Cephalic spine posterior, when the baby is head down and what is pointing toward you is the, actually spine posterior means the spine is not pointing toward me. The baby is laying like that to you. The anterior part is the baby's belly. So in this case, it's similar to how we are sitting now. The right of me is the right of the baby. The left of me is the left of the baby as well on the screen. and the spine is posterior. Because again, if you look at it, the spine is the part I don't see looking at it. So the spine is posterior. The anterior part actually is the belly. The baby's right is on the right side, baby's left on the left. So we are expecting to have the stomach on the left side. Right side is the portal splenic. Spine is posterior. This will be like that. And here, baby's left, baby's right, and the spine is at the bottom. And then you will have to have the apex pointing to the left. Normal situs. Cephalic with the spine anterior. Spine, so baby is giving me their back. In this case, it's the opposite. Baby's right is on the left side of the screen. Baby's left is on the right side of the screen. So I am expecting the baby's, the four-chamber heart, the apex has to be pointing toward the side where we had the stomach. Here again, cephalic with the spine posterior, with the spine anterior. And here is the example, spine anterior. The left side is having the stomach, right side is the portal splenic confluence. Cephalic with the spine to the maternal left side. Baby is cephalic, but now the spine is toward mommy's left side. So the most anterior part of the baby is the baby's right. Therefore, baby's right will be at the upper part, baby's left will be at the bottom part. And I have to be expecting the apex of the heart to be pointing to the bottom as well. Here again, spine to the mommy's right side, the baby's right at the upper part, the baby's left at the bottom where you see the stomach, where you see the apex of the heart is pointing as well. So normal situs. Cephalic with the spine to the mommy's right side, the opposite. The baby's upper part now is the left. See, I am cheating too. I look at it to make it make sense to me. So you can do that too. If you want to review while you are redoing this, while you are watching the video again after we are done, because we're going to publish the video in POCUS website. Have a doll with you in hand, have your note to put those together. So with cephalic, spine to mommy's right side, baby's left side is the one at the upper part of the screen. So that's the stomach, whereas the lower part, the one more posterior at the bottom of the screen is her right, portal splenic confluence. So I am also expecting the apex of the heart to be pointing here at the upper part, which we called it to the left for normal situs. And here is an example, stomach at the left, apex of the heart also pointing to the left, which we said has to be the upper part of the screen. Situs inverses is when the apex of the heart is not pointing to the left, to the level where we should have been having the stomach and the baby. You have at the beginning to know how the baby is sitting. Then based on how the baby is sitting, you want to know by anatomy where to expect the stomach to be sitting and where to expect the portal splenic confluence to be sitting. If it appears to be not matching the baby presentation, you will have the first heads up. There is situs inverses. So here is an example of situs inverses. Stomach on the right. Since when stomach on the right? Stomach has to be always on the left. So the first sign, you will see stomach on the right. You will see cardiac apex, the apex of the heart in 4 chambers of view, also pointing toward the right. How comes? And this is a heart in normal position, but this is dextrocardia abnormal position of the heart with a situation of situs inversus. And that's it. We are 5 minutes beyond, so that's good. At least it's not way further than 5 minutes above.
Thank you so much, Rawan.
Welcome.
A lot of information, but as Rawan mentioned, this is recorded and available, will be available within a week to you guys, and you can review it and watch it as many times as you would like. So we did have a lot of comments and a couple of questions during your presentation, so we can just address those. The first question was, is there any possibility that babies have shared placenta when they diachronic and diamniotic membrane?
When they are di-di, as I said before, di-di can be either sharing placenta or they can be, I will show you again, the di-di, remember, they can be either sharing or each one is having his own or her own. In here. You still see the slide?
Yes, we do.
Yeah. So in here, as I said, those are di-di. This situation, the lower left and lower right, both of them are di-di. Dichorionic, diamniotic. In this situation, as you can see, each one is alone. Each one of them is having his own or her own placenta. Whereas in this scenario, you can see both umbilical cord of each one of them is coming into one placenta. They are sharing the placenta in this situation. So we cannot say they are always shared or they are always having their own. Both situations are possible.
Okay. Thank you, Rawan.
Welcome.
One more question we got in Q&A box is, please explain the one YS. Not sure if that makes sense, or Ivana, maybe you can specify a little bit more.
I'm not sure I got the question.
Let me type it in for you, Rawan.
Okay.
Please explain better the one yolk sac and twins. Thank you.
Maybe if you mean by the number of yolk sac, how can I tell the chorionicity and amniocity? We can use, as we are using the T sign and lambda sign to distinguish between chorionicity and amniocity, using the lambda sign to say immediately it's dichorionic, or T sign to say immediately it's diamniotic. Even the number of yolk sac, the ring, how many of them you have, you will be able to tell if it's monoamniotic or diamniotic. So think of it as the number of yolk sac, the ring, is the number of the amniocity. One yolk sac, monoamniotic. Two yolk sac, you see two ring, immediately you can immediately, with no doubt, you're gonna be immediately confident telling it or naming it diamniotic. I hope this answered your question clearly. Let me see one example. Like in here, in this picture, the really beginning one, this, I see only one yolk sac. So I know with no doubt, this is monoamniotic. Because remember again, when during first trimester, from 9 to 12 week, what are you measuring? Or especially at 8 and 9 week of gestation, we want to see yolk sac to know that this is a healthy pregnancy. You are expected to be seeing the gestational sac, the yolk sac, and fetal pole. So by that time, because the yolk sac is actually sitting in the innermost bag, the amniotic bag. It's within the amniotic bag, not within the outer bag. Therefore, it can be going along with the amniocity by the number of yolk sac. 1 yolk sac, monoamniotic. 2 yolk sac, diamniotic. Hope this makes sense and answer it briefly.
Thank you so much, Rawan. I think we're at time, but I really appreciate. I have one last poll for the audience. If you can take a little bit of time and answer if this information that you learned today from the session applies to your specific job, and did you learn anything today? We really appreciate it. But we thank you everyone again. And Rawan, thank you for all 3 webinars. They have been amazing.
Thank you everybody for coming and for engaging within the webinar. It's my pleasure. Thank you, Daria, for everything.
Thank you. And thank you everyone who joined us today. We will have 2 webinars in April, so feel free to check our website and stay tuned for more information. We're looking forward to seeing you all soon. And if you have any questions for Rawan or myself, feel free to email to pocus@intellios.org and we'll get them answered. Thank you so much again, and have a great day or night, whatever you are. Thank you.
Yeah, have a good rest of your day and good night for those of you it's night here.
Thank you, Rawan.
Sure.